Hi, this is Nick Fogelson from Northwest Endometriosis and Pelvic Surgery. Just wanted to record another little video message that it's on a topic that I think is very important and I think is not discussed in as deep a way as perhaps it could be. And that topic is recurrence of pain after excision surgery or recurrence of endometriosis after excision surgery. There are data out on the internet that you see bouncing around that says that the rate of recurrence of endometriosis after thorough excision surgery is 10 to 15%. And these data are presented mostly by a couple of high volume expert excision practices who are as good as anyone is in the world, in my opinion. And they have gathered a data set that suggests that they have a recurrence rate of 10 to 15%. Conversely, I think you see a lot of women online who report that they do have recurrent pain after endometriosis, and they wonder, am I in that 10 to 15%? I mean, I'm just one of those rare people that had recurrence because the success rate of excision is 85 to 90%. Well, I want to kind of explain how both of these things can happen at the same time and how maybe they're not entirely accurate. First of all, I'd ask you to imagine if you wanted to design a study that answered the question, what is the likelihood of recurrence of endometriosis after thorough excision surgery? How would you design that study? So I'll give you a few seconds to think about it. How would you actually answer that question? Okay, so having trouble conceiving of how you do that? Perhaps. The reason why you would have trouble is that it's impossible. The only way to legitimately answer the question, do people have recurrent endometriosis after excision, would be to perform excision on a large number of women and before they have the first excision surgery, enter into an agreement with them that says, like, we're going to operate on you again in a year and we're going to look and see if you have endometriosis. Has that study been done? Of course not. Would that study be ethical to do? Of course not. No, you don't reoperate on people with the expense, risk, and pain of surgery who don't clearly need it. So unless you're operating on pigs and animals, which some people find unethical as well, we don't just operate on people purely for research in almost every circumstance. And yet that's the only way you could ever truly answer the question, what is the frequency of recurrence? And so instead you have these surrogates where you have a practice that has done a lot of endometriosis surgery, and then they take the subpopulation of people who had another surgery for one reason or another, and in that population of people, how many of them had recurrent endometriosis? And they come up with the answer, well, 10 to 15% of them of their population had recurrent surgery with recurrent endometriosis. I think that's how they do it, because the practices that describe these numbers are not very detailed in what their methodology is. It's not like a scientific paper where you would have to publish a very detailed materials and methods to explain exactly how you're coming up with the numbers. And other people can review it and say, I either agree with these materials and methods or not. I mean, that's what a peer-reviewed paper is that you have to write, what are you intending to investigate? How are you going to investigate it? What are your results? And then you discuss what that means to you. And then you got to present that to a bunch of other doctors, and they have to read it and agree that it's valid, and then they decide it can be published or not. Okay, that's peer review. If you just gather a bunch of data, process it anytime you like, any way you like, write something online, that's not peer review. It's just, it's just whatever you put. And to a bit of a criticism of the few practices that put out those numbers, they're not very descriptive about what their materials and methods are. So we really have very little idea of how they gather that information. But I can tell you they don't do it by the only way that's truly accurate, which would be to operate on everybody, because you can't do that. So when you report 10 to 15% of people have recurrence, you're only talking about the people that got reoperated on. They also state that, well, if people didn't have recurrent pain and they didn't have recurrent surgery, then they must not have had recurrent endometriosis. And so they take that patient who never had recurrent surgery, as far as they know, and say, well, they're a cured patient who didn't have endometriosis or didn't have recurrence. The problem is that if you run a practice particularly if you see people coming from out of state, which a lot of my practice sees a lot of people from out of state. I mean, any practice that is a kind of a referral center, by nature, people then spread back out and go to where they live. How do you follow up with those people and find out, did they have end up having another surgery? And if there was another surgery, was there endometriosis found? The answer is you can't very well. I mean, you can survey people and you can try to gather that information. And it's highly dependent on how much effort you put into it, how much money you put behind it. Are you paying a full-time research assistant that's tracking these people down, getting op notes? It takes a lot of time. I mean, you could easily have a full-time employee who generates no income just tracking all this stuff down for the purpose of having accurate information. And presumably they don't have that. And so instead what you're doing is a fairly, moderately effective trying to follow up on people. I can tell you that people do not follow up on these surveys very well. My practice does a 6-month, 12 months, and every 6-month survey on every patient we operate on. And there's probably about a 60% of the people fill out the 6-month survey, and then it goes down from there. And if we kind of hound them, maybe a few more will. So you're having a lot of drop off. The other problem is that the people that don't fill out your surveys, are you assuming that those people are an equal distribution of the people you survey? Meaning that if you get surveys back from 50% and then you don't get surveys back from 50%, are those 50% random, or are they a biased sample? Meaning that, is it more likely that people that do poorly, that don't have as good of results, don't turn in your survey than the people that do well? The answer is, I think probably the answer is yes. I think that if you're not really getting 100% of your surveys back, and someone that has great results, they're happy with their surgeon, they feel like their money was money well spent, they said, that doctor saved my life, they are far more likely to see that email asking for them to turn in a survey and to fill it out than the person who's had surgery and for whatever reason has recurrent pain and recurrent issues, or that had to have more surgery or whatever. So I think that when you are having a lack of complete follow-up, you're actually biasing yourself towards seeing better results than our reality. So for that reason, I think that these numbers of 10 to 15% recurrence are an underestimation of the actual rate of recurrence. Part of why I think that is that in my personal experience as an endometriosis surgeon, who I believe I do endometriosis excision surgery just about as good as anybody does. And I say that because I watch the videos of the best surgeons in the world and I watch what they're doing. And I don't see it happening any better than it does in my operating room, except for a very few cases with really unusual neuropelviologic stuff, deep pelvic floor surgery. That actually I'm still pretty good at, but occasionally I see someone that I think is doing a little bit more advanced stuff. Like I occasionally see that from a few people in Europe, not from anyone in the United States actually. So let's just say that I think I'm doing it as good as anybody is doing it. I don't get the results of only 10% of people have recurrent pain. I mean, that's not the results I get at all. I said the reality is that the vast majority of people who have excision surgery see a substantial improvement in their symptoms. And most people have some level of recurrent pain or some level of incomplete resolution of their pain. I tell patients that if they get 75, if a year after surgery they're 75% better than they were before surgery, then that's a huge success. And that if they're 50% better, that's some level of success as well. And that it's unlikely that they will have 100% resolution of their symptoms from any surgery I can do. Because the pelvis has gotten all inflamed from all this endometriosis, and all I can do is thoroughly remove the endometriosis, and then that tissue that's been removed is going to get replaced with scar tissue, which is fibrotic, and it can take a long time for that scar tissue to remodel and get soft. And it's never going to be as good as the pelvis of someone who never had endometriosis. And so, like, my personal experience, like, I've been discouraged in my career sometimes because I go like, wow, I don't get 90% effectiveness of excision. Maybe I'm not operating well enough. And yet when I look at the surgeries I do, I go, no, I'm doing the same surgery everyone else is doing. So I think that the methodology that leads certain practices to say they have a 90% success rate is flawed. And I don't know if those surgeons that report those rates, I I don't know. If they have some bias in the way that they look at it personally, or if they're not really thinking about it as academically as I am. I mean, I come from a really academic background where I really think about research methodology. And to me, I look at the methodology by which those data are gathered, and I say, well, that's very flawed, and it's very biased towards showing better results than our reality. And that's just what I would say. The second part of this is that there is an argument made by many good surgeons. I mean, red wine, I mean, I've made this argument at times. I mean, I heard from a lot of people that when there is recurrent endometriosis, it didn't recur. What happened was that the surgeon left it behind. And the implication is that if you had recurrent disease, then the surgery wasn't done quite well enough. And if you had seen a better surgeon, the surgery would have been more successful. And I see that all over the internet. I see a lot of women that report their stories to other people, other people with endometriosis, and say, I had endometriosis surgery and I'm having these recurrent issues. And the immediate kind of everyone comes in and gives this answer is like, oh, well, you should see this specialist or that specialist, and they must have left disease behind, and so forth. And I think it's much more complicated than that. As I always say, like everything to me is, I always think everything's more complicated. I don't think there's very simple answers to anything. There is definitely a plethora of bad endometriosis surgery out there. I mean, there's lots of general OBGYNs that mess around with endometriosis that don't have a chance of really eradicating the disease because they're just not thoroughly removing it at all. And, that's bad endometriosis surgery. But on the other end, there's the best endometriosis surgery anyone can ever do, and they still have recurrent disease sometimes. And the argument is, well, then they must have left disease behind. It couldn't have recurred. In my heart, I don't care about that. I mean, if someone says, well, they must have left it behind, what I know is that I have operated on patients that have had surgery before by the best surgeons in the world, including Ken Sinervo, David Redwine, Tamara Seshkin, you name it. I have done surgery, after they had surgery with the best surgeons in the world and they had recurrent pain for one reason or another, and not infrequently, I'm able to find endometriosis. That's not me criticizing those surgeons. That's me saying that the idea that the surgery done by the most experienced surgeons in the world is infallible is wrong. And furthermore, that the idea that if you had recurrent pain, it must mean that the surgery wasn't done well enough. That's not true either, because the reality is that the fundamental efficacy of excisional surgery is not perfect. That in the best hands in the world, excisional surgery will have some failures, and that's unfortunate. I mean, I think it's clearly the best thing that we have. It's certainly the best surgical treatment we have, and I would never recommend ablational surgery. I've seen so many patients have worse pain after ablation. I mean, clearly you go back and find significant amounts of endometriosis after ablation. I've seen ridiculous ablation surgeries where you look at the images and you're like, well, there's so much deep infiltrating disease there. The idea that you could ablate it away is just like psychotic. I mean, but the surgeon just doesn't really understand what they're looking at, most likely. So, I mean, clearly there's, I truly believe that excisional surgery is the best way to treat the disease surgically, and I have a whole practice based on it, and I offer it. But at the same time, I would not tell patients that there's a 90% chance that they'll be cured of endometriosis. I don't. There are other practices that report those data. All I can say is that that's not my experience. I think I'm doing it as good as anyone else is doing it. And I think that, there was a time in the past, years ago, where I said, well, maybe I'm not operating as well. Maybe that's why I'm not getting as good results. But I don't think that anymore. I think, no, we're doing it as good as you can reasonably do it. I think the problem is that endometriosis excision surgery has a certain failure rate. And in my opinion, it's higher than 10%. I know people are saying that 10%. I don't think that number is accurate. And I think the number is inaccurate for a variety of reasons. Part of why I want to say this is I feel like there's a population of women out there who have had excisional surgery and feel very marginalized because they didn't get the results that they wanted to get. And they believe that everyone else out there had tremendous success with excisional surgery and they didn't. And it makes people upset. I get a sense of it when I read this kind of stuff that they're upset that they're the exception. The reality is a lot of people do have really, really good results from excisional surgery, but not everybody does. And you're not like the huge outlier if you have some amount of recurrent pain. The reality is I think a significant portion of people that have excisional surgery continue to have some level of recurrent pain. And maybe it's from residual endometriosis, maybe it's from recurrent endometriosis, maybe it's from something else. It can be from interstitial cystitis, it can be from pelvic floor pain. And so it's also theoretical in a sense of like, are we judging our success on whether or not you can find endometriosis in the patient afterwards, or are we judging our success on whether or not quality of life is improved, whether or not pain is improved? And I would rather judge it on the latter, because I don't think patients come to you for endometriosis, although they think they do. I think they come to you for evaluation and management of pelvic pain or infertility. And so I think it's more honest to judge our outcomes by how did we address those subjective symptoms rather than whether or not someone could find endometriosis. Because if I operate on someone, they have recurrent pain a year later, and I operate again and I don't find endometriosis, do I go, I cured the endometriosis? Well, I mean, who cares? I mean, they have recurrent pain. So if I'm still going to be that patient's doctor and be her best doctor, I want to try to find out why else do they have pain. So they have pelvic floor problems. Do they have IC? Do they have neuropelviologic issues? Like, do they have vascular compression of nerves? And I try to evaluate that in my first surgery if it seems like it's appropriate. And to be completely honest, sometimes we don't know. I mean, there are people who don't have recurrent endometriosis. They don't seem to have pelvic floor pain. They don't seem to have IC, and they have recurrent pain. I don't think the patient's crazy, and I think it's kind of lame when physicians say the patient's crazy. But I'm just telling you that I don't think we always know the answer. So I try very, very hard to study and to improve myself and improve my surgical technique, but also to improve our intellectual understanding of pelvic pain and more methodology that we can use to address it. But even the best that I can do as a surgeon who's dedicated myself to being as good as I can be at this, I still fail sometimes. And I think everybody does. Every surgeon does. And so I think it's important to know that I think that excisional surgery is the best we have right now. There may be treatments in the future, like genetic treatments or other kinds of treatments that may be beneficial. I mean, hormonal therapy is helpful in some people, but it doesn't really treat the disease, but it does make people feel better in some cases. And there's probably things on the horizon. In the meantime, excisional surgery does have a pretty high rate of, quote, cure, where you no longer can find endometriosis. The rate of people who have complete resolution of their pain is going to be less than that, because some people do have pain for other reasons or for reasons that we don't understand. And finally, like if you have recurrent pain after excision, you're not alone. There are people that have that, and it's not extraordinarily rare. It's moderately common. I mean, I would say it's certainly more than 10% in my opinion. And it's not 12% either. It's like 20 or 30% probably. So the other thing I would just say is that there's different kinds of surgeries. Some surgeries, you see really bad disease, but it's very focal. And you can get a really good surgery where you really think you've gotten every bit of the disease. Like, it may have been deep, but it was in a focused area in the rectovaginal area, perhaps. You can get a nice wide excision. You can remove the bowel disease. And when it's done, the pelvis looks pretty healthy, and it seems like you've removed everything that anybody can remove. That's a case where probably you've obliterated the endometriosis and probably it won't recur. There are other cases where literally there's endometriosis everywhere. And in a patient that wants to preserve fertility also, that maybe she wants to preserve her ovaries, maybe she wants to preserve her uterus. And you can spend 4, 5, 6 hours like really thoroughly removing every bit of endometriosis you can. And you can deperitonealize nearly the entire pelvis. And I think you can do it as good as any human being, excellent surgeon can do it. I still think in those cases it's unlikely that you've removed all the endometriosis. And this is one of those subtleties versus simplicities. I think that people talk about complete excisional surgery or expert surgery, and they want to say that any case can be completely excised if the surgeon's good enough. I think if you want to talk about this from a little bit deeper complexity, the reality is that there are cases where the disease is just so extensive that it is unlikely that you're going to remove every cell of endometriosis from their pelvis. I just think that's unlikely. There are also cases where the disease is clearly like grown into the back of the cervix, where if they want to save their uterus, you're just not going to get it out. And you could call it adenomyosis at that point, but who cares? I mean, there's some sort of disease there that you're not removing while preserving fertility. And so again, I tell my patients, like, certain kinds of surgeries, I say, you know what, I really think we got it all because the nature of your disease was focused enough that I thought we could really remove it all and everything that was left behind looked very healthy. Other cases, I say, you had disease everywhere, and I did what I think is about as good of a surgery as anybody can do, but there's some likelihood that there's probably some amount of residual disease, and it may be that in the future, once you've completed childbearing, there may be a more extensive surgery that can be done to even more thoroughly remove anything that's there. Or it may take several surgeries to come back and find the few areas that have kind of regrown and so forth. So that's kind of a long message, but the subtlety of things is that the excisional surgery, I think, is quite effective, but it's not perfect. It's the best we got. It's very skill dependent on the point of the surgeon, but not every failure is because the surgery wasn't done perfectly. And that's what I have to say. I'm certainly interested in people's comments if they bothered to listen to all this. Thanks very much.